Today's topic of discussion is adverse drug reaction of the corticosteroid. Hello and welcome to Pharmacomania. I am Dr. Shahnaz Malik and we are going to discuss adverse drug reaction of the corticosteroid. Single dose of the corticosteroid is harmless and it is life-saving drug in anaphylactic reaction and acute adrenal insufficiency where it is useful as a single dose of the corticosteroid. So the use in the high doses for the longer duration of time like 2 to 3 weeks causes number of undesirable effect can occur and most of the adverse drug reaction are extension of their pharmacological action. So first of all is the metabolic effect on the carbohydrate metabolism. So hyperglycemia occur or aggravate pre-existing diabetes due to stimulation of glycogen deposition in the liver as well as gluconeogenesis from the other sources like amino acid and decrease peripheral utilization of the glucose. Ultimately what happens? Glucose will increase in the blood. Next is the Cushing habitus. It is the abnormal fat distribution causes peculiar features like moon face, buffalo hump and thinning of the limb. So prolonged use of the corticosteroid causes redistribution of the body fat and deposited over the neck, face and shoulder. Ultimately, what happened? Face become round like moon, so it is called moon face. Fat deposition over the back of the neck, so it is the buffalo hump, and fat deposition over the cheek, so face mouth, and thinning of the limb. Peptic ulcer formation in gastrointestinal tract. Sometimes it becomes hemorrhagic due to decreased local immune response against H. pylori infection and inhibit prostaglandin as well as pepsin secretion and aggravate peptic ulcer. Salt and water retention. Mineralocorticoid effect may cause edema and hypertension and even precipitate congestive heart failure, particularly in patients with primary hyperaldosteronism. They can be minimized by synthetic steroid like dexamethasone and betamethasone. Effect over the muscle. So, treatment with steroid for longer duration of time causes hypokalemia, lead to muscle weakness and fatigability. Long-term steroid therapy leads to steroid myopathy can occur. Effect on the bone. So, osteoporosis occur due to decreased formation of the osteoblast and increased formation of the osteoclast. Ultimately, pathological fracture of the vertebral bodies is common and ischemic necrosis of the femoral head can occur. Growth retardation in children may common with the dexamethasone and betamethasone, and in the eye, glaucoma and cataract may occur on the prolonged use of the corticosteroid. CNS adverse effects are like behavioral disturbance like nervousness, insomnia, mood change, psychosis can precipitate. On longer use of the corticosteroid like as an immunosuppressant, chances of opportunistic infection like fungal infection, viral infection and bacterial infection can precipitate. On inhalation steroid, local irritation and fungal infection of upper respiratory tract can occur and it can be prevented by the use of the spacer during the inhalation of the corticosteroid and rinsing of the mouth after inhalation of the corticosteroid. Now, hypothalamo-pituitary axis suppression is the most dangerous side effect on long-term use of the steroid, which decreases ACTH secretion through the negative feedback effect on the hypothalamus and pituitary gland and ultimately adrenal cortical atrophy can occur. So, hypothalamic pituitary adrenal axis. When some stress occurs, hypothalamus releases CRH. CRH will stimulate anterior pituitary and ACTH release, and ACTH will stimulate adrenal cortex to release cortisone. Now cortisone is present in the blood, then negative feedback will activate and it will inhibit hypothalamus to release CRH as well as anterior pituitary to release ACTH. So ultimately external steroid will suppress HPA axis and adrenal cortex atrophy and endogenous steroid synthesis will inhibit it. So abruptly stoppage of the corticosteroid will flare up the underlying disease being treated. Withdrawal symptoms like fever, myalgia, arthralgia, and malaise can occur, and acute adrenal insufficiency on exposure to stress, which manifest anorexia, nausea, vomiting, abdominal pain, hypotension, dehydration, hyponatremia, and hyperkalemia can occur. The important precaution to be taken during long-term steroid therapy to minimize the HPA axis suppression. So whenever possible, topical use is preferred. Short-term or intermediate-acting steroid should be preferred over the long-term, longer-acting steroid. Give steroid as a single morning dose at 8 a.m. or if daily dose is high, then administer two-thirds of the dose in the morning and one-third of the dose in the evening, which mimic the natural hormone release level in the and minimize the HPA axis suppression. Now, try alternative day therapy in chronic condition like in bronchial asthma, nephrotic syndrome, and systemic lupus erythematosus. In this condition, steroid should be given on alternate day. It is called pulse therapy. Withdrawal steroid after the long term, more than 2 weeks of the therapy, should be very slow or allowed to recover to normal adrenocortical function. The dose of the steroid should be tapered gradually and then stopped. It will take days or weeks or even longer for the HPA axis to recover after stoppage of therapy. During this period, the patient will require treatment with the steroid on exposure to the stress. If the patient on long-term steroid therapy is exposed to stressful condition like infection or major surgery, the dose of steroid administered should be increased to overcome stress. Now, mnemonics for the adverse drug reaction of the corticosteroids are C for Kazimood syndrome, O for osteoporosis, R for redistribution of the fat, T for thinning of skin, I for infection, C for cataract, and O for osteonecrosis of the neck of femur. S for stress ulcer, T for telangiectasia, E for euphoria, G for growth retardation, O for low potassium, and I for increased sodium, D for diabetes, and S for suppression of ACTH axis. Glucocorticoids are contraindicated in following conditions like hypertension, diabetes, peptic ulcer, tuberculosis, herpes simplex keratitis, osteoporosis, epilepsy, psychosis, congestive cardiac failure, and renal disease. In all these diseases, corticosteroids are contraindicated. Thank you for watching the video.